Now let me discuss about the antiarrhythmic drugs. Now before going into the discussion of the antiarrhythmic drugs, now you need to know a meaning of the word arrhythmia, right? You need to know what is called cardiac arrhythmias. The word arrhythmia means it is the deviation from the normal pattern of the cardiac rhythm is known as arrhythmia. Alright, so it is the word arrhythmia right, the word arrhythmia, it means that it is the deviation from normal pattern of cardiac rhythm. Right, deviation from normal pattern of cardiac rhythm. Right, and that is what is called as arrhythmia. Now you need to know what do you mean by the normal pattern of the cardiac rhythm, right? What are all there within the normal pattern of the cardiac rhythm? Now if you take the normal pattern, right, if you see the normal pattern, you take the normal heart rate of the individual. The normal heart rate of the individual, it should be 60 to 100 per minute. Right, the normal heart rate of the individual should be 60 to 100 per minute, and anything above 100 is tachyarrhythmia, and anything less than 60 per minute is your bradyarrhythmia. Alright, so less than 60 is bradyarrhythmia, more than 100 is tachyarrhythmia. Alright, next. So this is one of the normal pattern, and the second point about the normal pattern is the automaticity. Right, the second point regarding the pattern is the automaticity. Now what does this automaticity mean? That means that there are certain cells within the heart which are having their intrinsic property to generate the impulse, and the very important structure which has the high automaticity is your SA node. Right, it is your SA node. So remember a point, the impulse has to be generated within the SA node of the heart. Then only we consider it as the normal pattern of the cardiac rhythm. Alright, next. The other point in the normal pattern is after automaticity, that means after generation of the impulse within the SA node, remember a very important point, the impulse has to travel across the conduction pathway in a regular manner. In the sense, the impulse from the SA node, it has to pass through the internodal fibers, and from there the impulse goes to the AV node, and from there to the bundle of His, and from here it goes to right bundle branch and as well as the left bundle branch, and then the impulse moves to the Purkinje fibers. Now from the Purkinje fibers, the ventricular myocardium, right, from the Purkinje fibers, the ventricular myocardium will receive the impulse, then accordingly the ventricular myocardium either it will contract or it will relax. So one point in the normal rhythm, the heart rate should be in between 60 to 100 per minute. Second point is your automaticity, that is the generation of the impulse, that should be always within the SA node in case of normal cardiac rhythm. Third point, the impulse which has generated within the SA node, it has to pass through a normal conducting pathway. Only when these are there, we can use the word that the individual is having normal cardiac rhythm. Now, deviation from any of these normal pattern that is what is called as arrhythmia, right? That is what is called as arrhythmia. All right, next. Now let me tell you, so that like less than 60, right, less than 60, we call them as bradyarrhythmias, right? Less than 60 we call them as bradyarrhythmias, and more than 100 per minute the heart rate, right? More than 100 per minute, that is what is called as tachyarrhythmias, right? That is what is called as the tachyarrhythmias. Now, depending upon how much is your heart rate, the tachyarrhythmias are further classified. And if the heart rate, if it is in between 100 to 150 beats per minute, then we use the word a simple tachycardia, right? We use the word simple tachycardia. Next, if the heart rate of the individual, if it is in between 150 to 250 per minute, right? If the heart rate, if it is in between 150 to 250 per minute, then this is called as paroxysmal tachycardia, right? Then this is called as the paroxysmal tachycardia. Next, if the heart rate is in between 250 to 350 per minute, then we call this as flutter, right? We call this as flutter. And if the heart rate of the individual is more than 350 per minute, then we use the word fibrillation, right? Then we use the word fibrillation. Okay, so now these are all your arrhythmias now. Why? Because the heart rate is out of the normal limit of 60 to 100 per minute. Now remember, in order to have a proper understanding of the antiarrhythmic drugs, knowledge of the action potential of the heart muscle is necessary for understanding the basic pharmacology of the antiarrhythmic drugs. So now what I will discuss first is, I will discuss about the cardiac action potential, right? After having discussed about the cardiac action potential, next I'll move on to the discussion of the antiarrhythmic drugs. Now let me discuss about the cardiac action potential. If you take this cardiac action potential, this particular cardiac action potential, it differs significantly in different portions of the heart, right? So it differs significantly in different portions of the heart, right? In different portions of the heart. All right. Now another very important point what you need to remember is, now what are these different portions of the heart? What I mean to tell you here is, the cardiac action potential in case of the SA node, AV node and as well as bundle branches is different from the action potential within the ventricular muscle cell. So that is what I want to tell you, that the cardiac action potential, it differs significantly in different portions of the heart. And not only that, if you take the velocity of the conduction of the impulse, right, the velocity of the conduction of the impulse is also different in different portions of the heart. Next, now you see here, in a resting state, that is at rest, the myocardial cell, it has a negative membrane potential. So this is your RMP, that is resting membrane potential. So at rest, all right, at rest, okay, at rest, the myocardial cell, right, myocardial cell, it has a negative membrane potential. Right, it has negative membrane potential. Okay, so the resting membrane potential of the cell, it is negative, right? It might be around -80. Now whenever you give stimulus to the cardiac muscle fiber or the cardiac muscle cell, so when the stimulation, if it is above the threshold value, right, when the stimulus is given above the threshold value, that will induce the opening of the voltage gated ion channels. Okay, so whenever you give the stimulus, so remember, stimulation above the threshold value, right, stimulation above the threshold value will induce opening of, right, will induce opening of voltage gated ion channels, right, voltage gated ion channels. So whenever the myocardial cell receives the stimulus above the threshold value, there is opening of the voltage gated ion channels. Now once there is opening of this particular voltage gated ion channels, now into this particular myocardial cell there is entry of the cations, right? So next what will happen is, there is entry of cations, right? There is entry of the cations. So cations are what? They are positively charged ions. Right, cations are your positively charged ions. Okay, so once there is opening of the voltage gated ion channels, now into that particular myocardial cell there is entry of this particular cations, which are nothing but positively charged ions, right? So there will be entry of the cations inside the cell, right, entry of the cations inside the cell. Now once the positively charged ions enter into the cell, that will result in depolarization, right? That will result in depolarization. Okay, you see here, so resting membrane potential, it is negative, right? Resting membrane potential, it is negative. Now if the stimulus is given to this myocardial cell above the threshold value, there will be opening of the voltage gated ion channels. Now the positive ions will enter into the myocardial cell. Once the positive ions enter into the myocardial cell, that will result in the depolarization of the cell. So your phase 0, right, it is nothing but the depolarization of the cell. Is that clear? Now the other important point is, there are important physiological differences between the nodal cells, that is SA node and AV node. Right, there are important physiological differences between nodal cells and ventricular cells that give rise to a unique property to the SA node, right? So a very important point, this particular SA node, it has that intrinsic property of generating an impulse, and that is what is called as the automaticity, right? So SA node has the property of automaticity, right? And this particular automaticity is what is necessary for the pacemaker activity, right? This is necessary for the right, this is what is necessary for the pacemaker activity, right? So now let me shortly revise here until now what we have discussed. Remember, the cardiac action potential differs significantly in different portions of the heart. Now in a resting state, the myocardial cell has a negative membrane potential. Whenever you give a stimulus, right, stimulation above a threshold value induces the opening of the voltage gated ion channels. So once there is opening of the voltage gated ion channels, there is entry of the cations, that is positively charged ions inside the cell, and that will result in depolarization, right? That will result in depolarization. Next, the other point is, there are important physiological differences between the nodal cells and ventricular cells that give rise to a unique property to the SA node. But remember, this particular SA node most importantly, it is having a property of what is called automaticity, and this is very much necessary for the pacemaker activity of your SA node. Now let me discuss in detail about the resting membrane potential, phase 0, phase 1, 2, 3 and as well as phase 4. Now let me discuss about the resting membrane potential in detail. So if you take this particular resting membrane potential, remember resting membrane potential, it is phase 4 of your action potential, right? It is phase 4. So it is your phase 4 of the action potential. Now you need to know, why is this particular resting membrane potential created, or how is it caused? Remember, the resting membrane potential, it is caused by the difference in the ionic concentration and conductance across the cell membrane. Okay, so why is this resting membrane potential caused? This resting membrane potential, right, it is caused by difference in the ionic concentration, right, difference in ionic concentration and as well as difference in the conductance of the ions across the cell membrane, and conductance of ions across the cell membrane. So this particular difference in the ionic concentration across the cell membrane and this particular difference of conductance of ions across the cell membrane, this is what it creates a resting membrane potential. Now you take the normal resting membrane potential. Normal resting membrane potential of the ventricles, right, of the ventricles, it is around minus 85 to minus 95 millivolts. Right, the normal resting membrane potential of the ventricle is around minus 85 to minus 95 millivolts. Now the other point what you should remember here is this potential, right, this resting membrane potential is determined by the selective permeability of the cell membrane to various ions, right. Now if you take the cell membrane of the myocardial cell, right, this particular cell membrane of the myocardial cell is selectively permeable to various ions. Now the resting membrane potential is determined by the selective permeability of the cell membrane to various ions. Okay, so resting membrane potential is determined by selective permeability, right, it is determined by selective permeability of cell membrane to various ions, right, to various ions. Next, now you need to know, I have said you the word, the cell membrane is selectively permeable to various ions. Now you need to know to which particular ion the cell membrane of the myocardial cell is selectively permeable. Remember a point here, the membrane, that is the cell membrane of the myocardial cell is most permeable to potassium. Alright, so the cell membrane of the myocardial cell is most permeable right, it is most permeable to the potassium, and this particular cell membrane of the myocardial cell is relatively impermeable to other ions, right, it is relatively impermeable other ions. Okay, relatively impermeable to the other ions. So it is cell membrane of the myocardial cell is most permeable to the potassium, but it is relatively impermeable to the other ions. Therefore, potassium is the main cation that determines the resting membrane potential of the cardiac cell, right? This is a very important multiple choice question here. Okay, so resting membrane potential of the myocardial cell is determined by the potassium. Okay, so remember a point here, potassium is the main cation, right, is the main cation that determines, right, that determines the resting membrane potential of cardiac cell. Right, that determines the resting membrane potential of the cardiac cell. Now, let me tell you another important point. This particular potassium, it is the principal cation which is present within the cell. There are certain ions which are present within the cell, that is intracellular, and there are certain ions which are present predominantly outside the cell. Now, if you consider this as the cell, now let me tell you the ions which are predominantly present intracellularly and the ions which are present extracellularly. Right, the ions which are present intracellularly and the ions which are present extracellularly. Now, the ions which are present intracellularly, predominantly they are potassium and as well as the phosphate. And not only that, apart from the potassium and phosphate, even the conjugate bases of the organic acids, they are the one which are dominant anions which are present within the cell. Okay, so within the cell, what are all the various components which are present within the cell? One is your potassium, the other one is your phosphate, and the other one is your conjugate bases of the organic acids. Right, conjugate bases of organic acid. So these are the substances which are present intracellularly. Right, these are the substances which are present intracellularly. Now you take the ions which are present extracellularly. Right, you take the ions which are present predominantly extracellularly. The ions which are present predominantly extracellularly is your sodium and as well as the chloride. Right, sodium and as well as the chloride. So these are the ions which are present predominantly extracellularly. Alright, so let me shortly revise about the resting membrane potential here. Remember, resting membrane potential is your phase 4 of your action potential. The resting membrane potential is caused by difference in the ionic concentration and conductance across the membrane of the cell. When you take the normal resting membrane potential of the ventricle, it is around -85 to -95 millivolts. Now, this particular resting membrane potential is determined by selective permeability of the cell membrane to various ions. Now, you take this particular cell membrane, the membrane is most permeable to the potassium and it is relatively impermeable to the other ions. Therefore, potassium is the main cation that determines the resting membrane potential of the cardiac cell. Now, if you take the cell, like there are certain ions which are present predominantly intracellularly and there are certain ions which are present predominantly extracellularly. You take the ions which are present predominantly intracellularly, they include potassium, phosphate and conjugate bases of the organic acid. And the ions which are present predominantly extracellularly are sodium and as well as the chloride. Now, let me discuss about the phase 0 of the cardiac action potential. Right, let me discuss about the phase 0 of the cardiac action potential. Now, if you take this particular phase 0, remember phase 0 is the rapid depolarization phase. right? It is the rapid depolarization phase. Okay, so that is what is your phase 0. Now the other point is, if you take the slope of phase 0, the slope of the phase 0 represents the maximum rate of depolarization of the cell, and that is known as the Vmax. Okay, so if you take the slope of the phase 0, that represents maximum rate of depolarization, right? That represents the maximum rate of the depolarization of the cell, and this is what is called as Vmax, right? This is what is called as Vmax, that is velocity maximum. Now the other point is, you take this phase. Now why is this phase due to? A point what you should remember is, this phase, that is this phase 0, is due to the opening of the fast sodium channels. Now, so before going into the opening of the fast sodium channels, you need to know that this particular sodium channels, okay, so a point what you should remember is, the Vmax is due to the opening of the sodium channels. Now this particular sodium channels, they exist in 3 forms, right? These sodium channels, they exist in 3 forms. One, they are called as open sodium channels. Next, the other one, they are inactivated sodium channels, right? Inactivated sodium channels. And the third type is the closed sodium channels. So these are the 3 types of the sodium channels. Now let me tell you, why is this phase due to? Remember, this phase is due to the opening of the fast sodium channels. Okay, so this particular phase 0 is due to opening of the fast sodium channels. Now once this particular fast sodium channels open, what will happen is, a large quantity of the sodium will enter into the cell, right? So this will cause rapid influx of the sodium, right? This will cause the rapid influx of the sodium. And what is your sodium now? The sodium is a positive ion, it's a cation. So a positive charge, when it is entering into the cell in large quantities rapidly, that is why it will cause the maximum rate of depolarization, right? And that is why it is called as Vmax, right? That is why it is called as Vmax. Now let me discuss the concept of open, inactivated, and as well as the closed sodium channels. Now for example, you take a cell. When cell is stimulated, the sodium channels, they open and they result in the inward movement of the sodium. These channels then enter into an inactivated state, right? So what do you have here first? Initially the fast sodium channels, right? Initially what you have is the fast sodium channels. Now through this particular fast sodium channels, once the potential or once the depolarization occurs, the fast sodium channels open, there is rapid influx of the sodium, and followed by that, this open state of the sodium channels, they enter in an inactivated state, right? They enter into an inactivated state. Okay, so they enter into an inactivated state. Now in this particular inactivated state, so these channels then enter in an inactivated state from which these cannot be stimulated. So what do you understand by the word inactivated state? These cannot be stimulated. Right? These cannot be stimulated. Okay, so remember this point. Now later on, what happens next? Slowly the sodium channels, they recover from this inactivated state and they enter into the closed state. Okay, so what is the importance of your inactivated state? When the sodium channels are in the inactivated state, in spite of giving adequate stimulus to the cell, they will not get stimulated. Later on, these sodium channels from the inactivated state, they enter into the closed state. Right, they enter into the closed state. Now, in this stage, the channels can open on arrival of a sufficiently strong stimulus. Okay, so in the closed state, right, in the closed state, the channels, they can open whenever this particular channels receive sufficiently strong stimulus. Right, when the sodium channels in the closed state, when they receive sufficiently strong stimulus, they will open this particular sodium channels. Now, you take here the ability of the cell, alright, the ability of the cell to open the fast sodium channels, right, to open the fast sodium channels during phase 0 is related to the membrane potential at that point of excitation. I'll repeat again, the ability of the cell to open the fast sodium channels during phase 0 is related to the membrane potential at the moment of excitation, right, at the moment of excitation. So what I am trying to tell you here is, what is the resting membrane potential of the cell during the time of excitation? So the resting membrane potential of the cell will decide how much depolarization can occur within the cell. Alright, now for example, let me tell you a point here. If the membrane potential is at its baseline, right, for example, if the resting membrane potential, right, if the resting membrane potential of the cell is at its baseline, that is around minus 85 millivolts, right, that is around minus 85 millivolts. So if the membrane potential is at its baseline, all the fast sodium channels, they are closed, right, all the fast sodium channels, they are in a closed state, and at this point, whenever you give an adequate stimulus, and that adequate stimulus will excite the cell and will open all of this particular the fast sodium channels and causing a large influx of the sodium ions, right. So let me tell you the concept here very clearly. What I am trying to tell you here is, the opening of the fast sodium channels, whenever the stimulus comes to the cell, it depends upon the resting membrane potential of the cell at the point when the excitation comes. If the resting membrane potential is at its baseline, that is around minus 85 millivolts, at this point, all fast sodium channels, they are in a closed state, right, and whenever they are excited, right, all these fast sodium channels, whichever are in a closed state, whenever they are excited, they will open all these particular sodium channels and there will be large influx of there will be large influx of the sodium ions. Next, let me tell you the next important point. I have said you about what is called as Vmax. Now what is happening here? There is large influx of the sodium ions whenever all the fast sodium channels, whichever are in closed state, whenever they are opened by adequate stimulus. Now a point what you should remember here is, however, the membrane potential, if it is less negative, if at all, if the membrane potential is at -85, whenever you give adequate stimulus, all the sodium channels will open, right, and there is large influx of the sodium ions and there is Vmax. Now, if at all, right, for example, if at all, if the membrane potential, right, if the resting membrane potential, if it is less negative, right, if the resting membrane potential, if it is less negative, that means instead of -85 millivolts, if the resting membrane potential, for example, if it is like -70 or -60 or -50, that means what? The difference between the intracellular and as well as the extracellular gradient is less. If the membrane potential is -85, that means the gradient across the cell is very high. You give a stimulus, then all the sodium channels will open. If at all, if the resting membrane potential is less negative, that means instead of -85, if the resting membrane potential is like -60 or if the resting membrane potential is -50, that means what? The gradient across the cell, that is in between the intracellular and extracellular compartment, the gradient is less. Now, if the membrane potential is less negative, some of the fast sodium channels will be in the inactivated state. That means they are resistant to opening, thus causing a lesser response to excitation of the cell membrane, and that will result in what is called as lower Vmax. So what I want to tell you here is, if the resting membrane potential, if it is less negative, some of the fast sodium channels some of the fast sodium channels, they will be in the inactivated state, right? They will be in the inactivated state, that is, they are resistant to opening. That is, they are resistant to opening. So, some of the fast sodium channels, they are in the inactivated state, they are resistant to opening, thus causing a lesser response to excitation. Right, thus causing lesser response to the excitation of the cell membrane, and thereby what will happen? There is lower Vmax, right? Thereby what will happen is there is lower Vmax. Okay, now for this reason, right, for this reason, if the resting membrane potential becomes too positive, the cell may not be excitable and conduction through the heart may be delayed. So, if the resting membrane potential is more negative, then it means that the gradient across the cell is more. You give an adequate stimulus, then all the fast sodium channels will open and there is large influx of the sodium and there is a Vmax, right? There is a rapid depolarization. But instead of that, if the resting membrane potential is less negative, or if the resting membrane potential becomes too positive, then the cell may not be excitable and conduction through the heart may be delayed, right? Now, this increases the risk of arrhythmias, right? This increases the risk of arrhythmias. So, what I want to tell you here is, if resting membrane potential, if it is less negative or if it is too positive, then the conduction is delayed, right? Then the conduction is delayed, right? and once the conduction is delayed, this increases the risk of arrhythmias. Right, this increases the risk of arrhythmias. Okay, so that is about the discussion about the phase 0. Right, so let me shortly revise about the phase 0. Remember, phase 0 is your rapid depolarization phase. The slope of phase 0 represents the maximum rate of depolarization of the cell, and that is known as Vmax. Right, that is known as the Vmax. And this particular phase is due to opening of the fast sodium channels, causing the rapid influx of the sodium ions. Now these sodium channels, they exist in three forms. One is open, that is open state of the sodium channels, inactivated state, and as well as the closed state. Now once the cell is stimulated, right, once the cell is stimulated, the sodium channels open and they result in inward movement of the sodium for a brief period. Later on, these channels, they enter into the inactivated state, from which these cannot be stimulated, however might be the stimulus. Now slowly the sodium channels recover from the inactivated state and enter into the closed state. In this stage, the channels can open on the arrival of a sufficiently strong stimulus. Alright, next. The point is, the ability of the cell to open the fast sodium channels during phase 0 is related to the membrane potential at that moment of excitation. That is, if the membrane potential is at its baseline, that is about minus 85 millivolts, all the fast sodium channels are in a closed state and excitation will open all of them, and that causes a large influx of the sodium ions. However, if the membrane potential is less negative, some of the fast sodium channels will be in the inactivated state, thus causing a lesser response to the excitation of the cell membrane, and that will result in what is called as the lower Vmax. Now, for this reason, if the resting membrane potential becomes too positive, or if it is less negative, the cell may not be excitable and the conduction through the heart may be delayed. This increases the risk of arrhythmias. Now let me discuss about the phase 1 of the cardiac action potential. So if you take phase 1 of the cardiac action potential, remember phase 1 of the action potential occurs with the inactivation of the fast sodium channels. Let me tell you what are the changes which are taking place in phase 1. Number 1, there is inactivation of, right, there is inactivation of fast sodium channels. Now, so once there is inactivation, right, once there is inactivation of the fast sodium channels, in spite of whatever might be the stimulus, the sodium channels, they do not get open, right, so they become inactivated. That is the first thing. Second point is, second reason why you are getting that particular phase 1, the downward deflection of the action potential. So what are you having in phase 1? In phase 1, there is downward deflection of the action potential. So the downward deflection of the action potential is due to the movement of the potassium and as well as the chloride, right? So what will happen is, the potassium from the cell, it tries to move out of the cell. Okay, so the downward deflection Alright, the downward deflection of the action potential is due to the movement of right, is due to the movement of the potassium and chloride. So the potassium, it starts moving out of the cell in large quantities, right, and potassium is a positive ion. So once the cation moves out of the cell, then the depolarized cell will start its repolarization, right, the depolarized cell will start its repolarization. Okay, now you take phase 2. Right, you take phase 2. This is called as the plateau phase of the cardiac action potential. Right, this is called as plateau phase of cardiac action potential. Okay, so it is exactly the straight horizontal line, that is your phase 2, and that is what is called as your plateau phase. Okay, now so this plateau phase of the cardiac action potential is sustained by a balance, right, and what is the balance? It is sustained by a balance between the inward movement of the calcium through L-type calcium channels and outward movement of the potassium through the slow delayed rectifier potassium channels. Okay, so what is there? There is a balance. That means neither there is depolarization, neither there is repolarization of the cell. Now there is a balance here. So what is the balance here is, or how is the balance maintained, right, and why are you getting that particular plateau phase? So the balance is in between, right, the balance is in between the inward movement of the calcium right, inward movement of calcium through L-type calcium channels right, through L-type calcium channels. So positive ions are entering into the cell, and at the same time what will happen is the positive ions, they move outwards, they move out of the cell. Okay, so there is a balance between the inward movement of the calcium through L-type calcium channels and outward movement of the potassium. Right, outward movement of the potassium through the slow delayed rectifier potassium channels, right, through slow, right, through slow delayed rectifier potassium channels. Okay, so positive ions are entering into the cell, and at the same time positive ions are moving out of the cell, and thereby there is a balance which is being maintained, due to which you get a plateau phase of the cardiac action potential. Now later on, after phase 2, what you have is phase 3. Now let me discuss what will happen in phase 3. Right, let me discuss what will happen in phase 3. Now during phase 3 of the action potential, the calcium channels, they close, right, the inward movement of the calcium does not occur in phase 3. So in phase 3 what will happen is the calcium channels right, the calcium channels, they close, while the potassium channels, right, while the potassium channels, they are still open, right, while the potassium channels, they are still open. Now once the potassium channels are still open, this ensures a net outward current which is responsible for repolarization. So when the potassium channels are still open, the potassium will be moving out of the cell, and that is responsible for, right, outward movement of, right, outward movement of potassium that will result in repolarization. Alright, that will result in repolarization. Next, now you take these potassium channels, the delayed rectifier potassium channels, they close. When do they close? When the membrane potential is restored to minus 80 to minus 85 millivolts, that is the point when the potassium channels will close. Okay, so these potassium channels, they close. Right, these potassium channels, they close when the resting membrane potential is restored to minus 80 to minus 85 millivolts. Alright, when the resting membrane potential reaches to minus 80 to minus 85 millivolts, that is the point when the potassium channels will close. That is about your phase 3. So remember, in phase 3 the calcium channels will close, the potassium channels are still open, so that is the reason why there is outward movement of the potassium, and that will result in what is called as repolarization, and this particular potassium channels, they will close once the resting membrane potential reaches to minus 80 to minus 85 millivolts. So that is about your phase 3. So we have discussed about phase 1, right, that is due to inactivation of the fast sodium channels. That means the sodium channels are completely closed, and there is downward deflection is because of the movement of the potassium and chloride out of the cell. But the movement of your potassium out of the cell is more compared to that of the chloride which is moving out of the cell. And you take phase 2, that is plateau phase of the cardiac action potential, and this particular plateau phase is due to a balance between the inward movement of the calcium through L-type calcium channels and outward movement of the potassium through slow delayed rectifier potassium channels. And then you have phase 3. Now let me discuss in detail about phase 4. Right, let me discuss about the phase 4. Now phase 4, as already we have discussed, this is the resting membrane potential. Right, this is the resting membrane potential. Right, that is when the cell is not being stimulated. Right, in phase 4. Alright, so in phase 4 the cell is not being stimulated. Now a point what you should remember is, it is during this phase 4 the heart is in the phase of relaxation. So this phase 4, that is this phase, is associated with diastole. Alright, it is associated with the diastole. Okay, next. Now remember, certain cells of the heart, they have the ability to undergo spontaneous depolarization, in which an action potential is generated without any stimulation, and that is what is called as the automaticity. Now for example, you take the SA node. In case of the SA node, the action potential is not similar to this. Okay, so they have the action potential in this way. Okay, so this is the resting membrane potential. Right, this is the resting membrane potential for the SA node. Right, so what does that mean? This particular resting membrane potential, it is not like a flat line. Right, so you have a leaky sodium channels, right, within the SA node. Why you have the resting membrane potential being unstable is the SA node contains a leaky sodium channels. Because of the presence of the leaky sodium channels within the SA node, continuously there is inward movement of the sodium channels even during the resting phase. Right, now once there is leakage of the sodium channels adequately up to the threshold, then it can fire on its own. That is what is called as automaticity. So remember, certain cells of the heart, right, certain cells of the heart, what do they have? Certain cells of the heart, they have the ability to undergo, right, they have ability to undergo spontaneous depolarization. Alright, they have ability to undergo spontaneous depolarization, in which, right, in which the action potential is generated, right, in which the action potential is generated without, right, without adequate stimulus, and this is what is called as automaticity. Okay, so this is what is called as automaticity. Now, this particular spontaneous depolarization is fastest in the SA node of the heart, right? This spontaneous depolarization, it is fastest. Where is it fastest? It is fastest in the, right, it is fastest in the SA node of the heart, and therefore this particular SA node, this is considered as the pacemaker, right? Therefore this particular SA node is considered as the pacemaker. Now the other point what you should remember here is the electrical activity that generates in the SA node is propagated to the entire heart. Right, the electrical activity which is generated within the SA node is propagated to the entire heart. So this is what is the phase 4, that is resting membrane potential. So remember here the cell is not being stimulated, and phase 4 is associated with the diastole of the heart, and certain cells of the heart, they have ability to undergo spontaneous depolarization, that is the action potential is generated without stimulation, and that is what is called as the automaticity. Next, if you take the spontaneous depolarization, the spontaneous depolarization is fastest in the SA node of the heart, therefore it is considered as the pacemaker of the heart, and the electrical activity that originates from the SA node is propagated to the entire heart. Now let me correlate, right, the various phases of the action potential with the ECG. Okay, so relation between the various phases of the action potential and the ECG. Now, if you take the ECG, that is the electrocardiograph, let me tell you what are the waves in the ECG. So you have what is called as the P wave, then you have the QRS complex, then you have the T wave. Right, then you have the T wave. So P, QRS, and then the T wave. Now you take phase 0 and as well as phase 1, right? Phase 0 and phase 1, they will correlate with the QRS complex of the ECG. What is QRS complex? It is nothing but your ventricular depolarization. So in the entire cardiac action potential, where is like your depolarization taking place? That is in phase 0, right? And so remember, phase 0 and to certain extent phase 1, it corresponds to QRS complex. So phase 0 and as well as phase 1, it corresponds to the QRS complex. Now later on you take the phase 2, right? You take phase 2. Now if you see the waves here, like you have Q, R, S, and then T wave. Now in between the S wave and as well as the T wave, this is what is called as the ST segment. Right, this is what is called as the ST segment. Okay, the isoelectric baseline what is there in between S and T is what is called as the ST segment. Remember, the ST segment of your ECG, it corresponds to the plateau phase. Right, it corresponds to the plateau phase. Right, this is a very important point that you need to remember. So ST segment of the ECG, it corresponds to the plateau phase. Now you take the T wave. What does the T wave represents in the ECG? It represents the ventricular repolarization. So in the cardiac action potential, which phase corresponds to the repolarization? That is your phase 3. So phase 3, it corresponds to your T wave. Right, phase 3, it corresponds to your T wave in the ECG. So what is your T wave? T wave is nothing but repolarization. Alright, T wave, it corresponds to the repolarization of the cardiac action potential. So remember, phase 0 and phase 1, that corresponds to the QRS complex. Phase 2, it corresponds to the ST segment, that is your plateau phase. Phase 3, it corresponds to the T wave of the ECG, which is nothing but repolarization phase. Now, after having discussed about the cardiac action potential, now let me discuss about the antiarrhythmic drugs. Now, if you take this particular antiarrhythmic drugs, alright, this antiarrhythmic drugs, they are classified into 5 classes, that is class 1, 2, 3, 4, 5. And the name of this particular classification is, it is Singh and Vaughan-Williams classification of the antiarrhythmic drugs. So it is called as the Singh and Vaughan-Williams classification. Vaughan-Williams classification, right? So this is the classification of the antiarrhythmic drugs. Now, a point what I want to tell you here is, this particular scheme, that is, this scheme classifies a drug based on its primary mechanism of action, right? So this classification is based on the mechanism of action of the antiarrhythmic drugs. Now there are totally 5 main classes. Right, there are totally 5 main classes. Now you take class 1. Class 1 antiarrhythmic drugs, they are sodium channel blockers, right, they are sodium channel blockers. Then you take class 2 antiarrhythmic drugs, they are beta blockers. Alright, they are beta blockers. Then you take class 3 antiarrhythmic drugs, right? Class 3 antiarrhythmic drugs, they are potassium channel blockers. Right, they are potassium channel blockers. Then you have class 4 antiarrhythmic drugs. So if you take class 4 antiarrhythmic drugs, they are calcium channel blockers. Alright, they are your calcium channel blockers. And class 5 antiarrhythmic drugs, they are miscellaneous drugs. Right, they are your miscellaneous drugs. Now let me discuss about the class 1 agents. Right, let me discuss about the class 1 agents. So if you take this class 1 agents, remember the class 1 antiarrhythmic agents, what do? They interfere with the activity of the sodium channels, right? So class 1 antiarrhythmic agents, they interfere, right? They interfere with the activity of right, they interfere with the activity of the sodium channels. Alright, they interfere with the activity of the sodium channels. Now, you take the sodium channels in your cardiac action potential. So, which phase was requiring your sodium channels? Remember, it was your phase 0. So in phase 0, once the cardiac muscle cell, once it receives adequate stimulus, the sodium channels they open and the sodium enters into the cell, and that will result in the rapid depolarization. Okay, so now once these class 1 agents interfere with the activity of the sodium channels, thus all of these drugs can decrease the slope of phase 0, right? So all these drugs, right, all these drugs, they decrease the slope of, right, they decrease the slope of the phase 0, right? And what is this phase 0 considered as? Vmax. Now why do we consider it as Vmax? Because there is opening of the fast sodium channels, a large quantity of the sodium enters into the cell, and there is rapid depolarization what is taking place in your phase 0. So that is why we use the word Vmax. Now most frequently the sodium channels they open, and so what I want to tell you here is, more is your sodium channels that get opened, greater will be the blockade by these particular drugs. So that is, it is use dependent blockade. Okay, so remember a point here, most frequently the sodium channels open, right, most frequently the sodium channels open, right, most frequently the sodium channels open, greater will be the blockade, right, greater will be the blockade by this drugs, right, greater will be the blockade by these drugs, right, and this is what is called as a use dependent blockade. Right, this is what is called as use dependent blockade. Okay, next. Now remember, this particular class 1 agents, they are classified according to the action of these drugs on the potassium channels. Okay, so if you take class 1, this particular class 1, we again classify this into 3 types, right? We again classify this into 3 types, that is class 1A, then you have class 1B, and then you have class 1C, right? 1A, 1B, and then 1C. Now how are these further classified? These again class 1 are further subclassified into 1A, 1B, 1C according to action of these drugs on the potassium channels. Right, according to action of these drugs on the potassium channels, these are again further subclassified into 1A, 1B, and then 1C. Now let me discuss in detail about what are 1A drugs, what are 1B drugs, and what are 1C drugs, and how do they affect the potassium channels, right? So before going into further discussion, let me shortly revise about the class 1 agents. Remember, these class 1 agents, they interfere with the activity of the sodium channels. So all these drugs, they decrease the slope of the phase 0, because phase 0 is because of the sodium channels, right? And most frequent, so more is the quantity of the sodium channels that are being opened, greater will be the blockade by this particular drugs, and this is what is called as a use dependent blockade. And these class 1 agents are again subclassified into 1A, 1B, and 1C based on the action of these drugs on the potassium channels. So now let me discuss about class 1A, 1B, and then 1C agents. Now let me discuss about the class 1A agents. Remember, class 1A agents, apart from its action on the sodium channels, so what do they do for the sodium channels? They block the sodium channels. Apart from its action on the sodium channels, these drugs also block the cardiac potassium channels. Okay, so these class 1A agents, apart from blocking right, apart from blocking the sodium channels, right, these class 1A agents, they also block, right, they also block the cardiac potassium channels. Right, they also block the cardiac potassium channels. Now, the sodium channels were concerned with your phase 0 of action potential, whereas you take the potassium channels, they were concerned with the repolarization of the action potential. So, if the potassium channels, once they are opened, the potassium which is there within the cell will move out of the cell, and thereby the cell will start repolarizing. But here what is happening? These class 1A agents, they are blocking the cardiac potassium channels. So once there is blocking of the cardiac potassium channels, there is delay in the repolarization. So once there is blocking of the cardiac potassium channels, thus they will cause delaying of the repolarization. So there is right, so there is delaying repolarization. Now, so once the repolarization is delayed, what will happen? There will be a prolonged action potential duration. So this will result in a prolonged action potential duration. So what I want to tell you here is, with class 1A agents, the cardiac action potential duration increases, right? This is a very important multiple choice question here. Now, due to prolongation of the action potential duration, right? Due to prolongation of the action potential duration, these drugs can precipitate the Torsades-D point test. I'll tell you what is Torsades-D point test, okay? So, due to prolongation of the action potential duration, these drugs, right, these drugs can precipitate Torsades-D point test, right? These drugs can precipitate the Torsades-D point test. Now what exactly will happen here? Now why there is action potential duration increased? I mean, what does that represent? In the ECG, remember, prolonged action potential duration in the ECG, it is represented by a prolonged QT interval, right? It is represented by a prolonged QT interval. Now if you take the normal QT interval, the normal QT interval is around 360 to 440 milliseconds, right? And sometimes it may extend even up to 460 milliseconds, okay? So if you take the normal QT interval, so in this normal QT interval, this might be up to 360 to 440 milliseconds. Some individuals, it may even be 460 milliseconds as well. Now, whenever you are using these drugs, what are these drugs doing? They are blocking even your repolarization, and thereby the action potential duration is increased, and this increased action potential duration is represented on the ECG by your prolonged QT interval, So remember, whenever there is a prolonged QT interval, that will precipitate, and these individuals, they have risk of developing arrhythmias, right? Now what is your Torsades-D point test? This Torsades-D point test, this is your a polymorphic ventricular tachycardia, right? It is a polymorphic ventricular tachycardia. It's a type of arrhythmia, right? And so remember, those particular drugs which will increase the QT interval, they have the risk of tendency of developing Torsades-D point test. Torsades-D point test, it is a type of arrhythmia, and what arrhythmia is that? It is a polymorphic, that means the individual has ventricular tachycardia of variable morphology. That is what is called as polymorphic ventricular tachycardia. Alright, next, let me tell you the agents in this class. They also cause decrease in the conductivity of the impulse, and they will also increase the refractoriness of the cardiac cell. Okay, so right, so the agents in this class, they will also cause decreased conductivity of the impulse, and not only that, these agents, they will also cause increased refractoriness of the cardiac cell. Right, they will also cause increased refractoriness of the cardiac cell. Now, you take the decreased conductivity, right? Why there is decreased conductivity? Because the action potential duration is prolonged. So once the action potential duration is prolonged, for the next cell to get depolarized, the previous cell action potential duration should be completed, and then the next cell will be depolarized. But what is happening to your previous cell? To the previous cell, the action potential duration is increased. That is the reason why the subsequent cell, for its depolarization, it takes a prolonged period. So the subsequent depolarization will be delayed, and that is the reason why there is decreased conductivity by your class 1A agents. Now, what do you mean by the word refractoriness? Refractoriness means refractory period is that particular period during which the second stimulus will not stimulate the cell when the cell is in the phase of depolarization, right? What is refractory period? When the cell is in the state of depolarization, during this particular phase, if the cell receives second stimulus, it will not respond to the second stimulus. That is what is called as refractory period. Now, because the action potential duration is prolonged, the cell will try to be more in the refractory period. So that is what is called as, these drugs, they will increase the refractoriness of the cardiac cells. Now the other points, if you see, remember, these drugs dissociate from the sodium channels with intermediate kinetics, right? So the pharmacokinetics here is, it is the intermediate kinetics, right? They dissociate from the sodium channels with intermediate kinetics. Now the other point is, you take the time of recovery. The time of recovery of the sodium channels is 1 to 10 milliseconds. Right, the time of recovery, of this particular sodium channels is around 1 to 10 milliseconds. Right, it is around 1 to 10 milliseconds. Now, what are the examples of your class 1A agents? The drugs include quinidine, then you have procainamide, right? Then you have procainamide, and then you have another important drug, that is disopyramide. Right? Then you have another important drug, that is disopyramide. So quinidine, procainamide and disopyramide, these are the important members of your class 1A agents. Now first let me discuss about the quinidine. So before going into the further discussion about the quinidine, let me shortly revise here. Remember, class 1A agents, apart from blocking the sodium channels, they also block the cardiac potassium channels, and thereby delaying the repolarization, resulting in prolonged action potential duration. So due to prolongation of the action potential duration, these drugs can precipitate what is called as the 𝐃𝐨𝐬𝐧𝐷 point test, and that is what is represented on the ECG by your prolonged QT interval. And you take the normal QT interval, that is around 360 to 440 milliseconds. And what is your 𝐃𝐨𝐬𝐧𝐷 point test? It is nothing but it's a form of polymorphic ventricular tachycardia. Next, agents in this class also cause decreased conductivity and increased refractoriness. Next, these drugs dissociate from the sodium channels with intermediate kinetics, and the time of recovery of the sodium channels is around 1 to 10 milliseconds. And if you take the drugs in your class 1A agents, they include quinidine, procainamide and disopyramide. They are the important members of the class 1A agents. Now let me discuss about the class 1A agents in which it includes quinidine. Right, in which it includes quinidine. Now remember, quinidine, it is a derivative of the cinchona plant. Right, it is the derivative of the cinchona plant. Remember, this quinidine, it is also having anti-malarial action, but the anti-malarial action of the quinidine is poorer than quinine. Okay, so right, anti-malarial action, it is poorer than quinine. All right, now you take the adverse effects of this particular quinidine. The adverse effects of the quinidine, they include nausea, vomiting and diarrhea. They are the most common side effects of these drugs. So nausea, vomiting and as well as diarrhea. Right, so these are the most common side effects of this particular quinidine. Now the other important adverse effects of this particular quinidine is that it can cause profound hypotension and hypoglycemia. Right, it can cause hypotension and as well as the hypoglycemia, that is decrease in the blood glucose levels. Right, that is decrease in the blood glucose levels. Now the point what you should remember here is, due to its myocardial depressant action, remember quinidine, it has the myocardial depressant action. So due to its myocardial depressant action, it can precipitate the heart failure in patients with low cardiac reserve. Okay, so quinidine, due to its myocardial depressant action, alright, due to its myocardial depressant action, this particular quinidine can precipitate the heart failure. Right, this particular quinidine can precipitate the heart failure in patients with low cardiac reserve. Alright, in patients with the low cardiac reserve. Now, so remember, this quinidine is derived from the cinchona plant. Whenever you give overdose of this quinidine, in overdose it can result in synchronism. Okay, so whenever there is overdose of this quinidine, that will result in what is called as, right, that will result in what is called as the synchronism. Now how is this particular synchronism manifested? This synchronism, right, this synchronism, it is manifested, or it manifests as tinnitus, right, or it manifests as the vertigo, and the individual can have even deafness, right, the individual can have even deafness, and they can also have headache, right, they can also have headache, visual disturbances, right, visual disturbances, and as well as the mental changes. Right, visual disturbances and as well as the mental changes. Now, apart from this particular synchronism, remember this particular quinidine, it has a drug interaction with digoxin, right? Digoxin is a cardiac glycoside. Now what it will do to the digoxin is, this particular quinidine, it decreases the renal clearance of digoxin and it decreases the biliary clearance of digitoxin. So that is the reason why whenever you are giving quinidine along with digoxin, What the quinidine will do? Quinidine can precipitate the digitalis toxicity, right? The quinidine can precipitate the digitalis toxicity. Okay, so remember this quinidine, it decreases the renal clearance, right? It decreases the renal clearance of digoxin, and it decreases the biliary clearance of, right, biliary clearance of digitoxin. So thereby, what does your quinidine do? The quinidine may precipitate, right? Quinidine may precipitate digitalis toxicity, right? Quinidine may precipitate the digitalis toxicity. So these are some of the important points regarding the quinidine. So let me shortly revise about the quinidine. Remember, quinidine is a drug which is derived from the cinchona plant, right? And its anti-malarial action is poorer than quinine. And the adverse effects, they include nausea, vomiting and diarrhea. They are the most common side effects of this particular drug. And this particular quinidine can cause profound hypotension and as well as hypoglycemia. And the other point is, this quinidine, it has the myocardial depressant action. Due to its myocardial depressant action, it can precipitate the heart failure in patients with the low cardiac reserve. And in case of quinidine overdose, it will result in what is called as the synchronism, right? And that manifests as tinnitus, vertigo, deafness, headache, visual disturbances and mental changes. Next, you take this particular quinidine. Quinidine, it decreases the renal clearance of digoxin, and it also decreases the biliary clearance of digitoxin, and thereby the quinidine may precipitate the digitalis toxicity. So let me discuss about another class 1A agent, that is procainamide, right? Another class 1A agent, that is procainamide. Now if you take this procainamide, remember this is an orally active derivative of a local anesthetic, that is procaine. Okay, so it is a derivative of, right, it is derivative of a procaine. Now what is this particular procaine? This procaine, it is a local anesthetic agent, right? It is local anesthetic agent. And how is this procainamide given? It is given orally, right? Now you take the metabolism of this procainamide. Remember, this procainamide is metabolized in the liver, right? It is metabolized in the liver, and it is metabolized by what is called as acetylation, right? It is metabolized by what is called as acetylation. So once this procainamide is metabolized by acetylation, what is being produced is, right, what is being produced from the procainamide is N-acetyl procainamide, right? N-acetyl right, N-acetyl procainamide. So N-acetyl procainamide is formed by acetylation of this particular procainamide. Now what is the property of this N-acetyl procainamide? This N-acetyl procainamide, that will retain the potassium channel blocking activity, right? So this N-acetyl procainamide, it has, right, it has potassium channel blocking property, right? So that is an important point about the N-acetyl procainamide. Now you take the acetylation, right? Remember, there are fast acetylators and as well as slow acetylators. right? There are fast and as well as the slow acetylators of the procainamide. So basically procainamide is undergoing metabolism by acetylation. So you have the fast acetylators of the procainamide and you also have the slow acetylators, right? You have the fast and as well as the slow acetylators of the procainamide, right, of procainamide. Now a point what I want to tell you here is, you take those group of individuals who are slow acetylators, right? Remember, in those individuals who are slow acetylators, long term therapy with high dose of this drug can result in drug induced lupus erythematosus, right? That is particularly in the slow acetylators. Okay, so remember, in case of slow acetylators, right, in case of slow acetylators, long term therapy, right, long term therapy with high dose of this procainamide can result in drug induced lupus erythematosus, right, can result in drug induced lupus erythematosus. Okay, so this in case of slow acetylators. Now you take the indications of class 1A agents, right? So let me tell you the indications of class 1A agents. So if you take the indications for class 1A agents, they include number 1, supraventricular tachycardia, and another indication is your VT, that is ventricular tachycardia. Next, they are also indicated in case of, right, they are also indicated in case of symptomatic ventricular premature beats, right, symptomatic ventricular premature beats. Next, they are also indicated in the prevention of ventricular fibrillation. Right, they are also indicated in the prevention of ventricular fibrillation. Okay, so these are the indications of class 1A agents. Now let me tell you, you take procainamide and as well as quinidine. While procainamide and quinidine may be used for conversion of atrial fibrillation to normal sinus rhythm, but remember, they should only be used in conjunction with AV node blocking agents. Okay, so if you take this procainamide and as well as the quinidine, they can be used for the conversion of, right, they can be used for the conversion of atrial fibrillation to normal sinus rhythm, right? But whenever you use procainamide and quinidine for the conversion of atrial fibrillation to normal sinus rhythm, they should only be used in conjunction with AV node blocking agents, right? So along with these drugs, you should give AV node blocking agents. Now what are those AV node blocking agents? The AV node blocking agents, they include digoxin, they include verapamil, which is a calcium channel blocker, and the other agent, they include the beta blockers, right? The other agents, they include beta blockers. Now the question is, right, why you need to combine procainamide and quinidine along with the AV nodal blocking agents, right? Because these drugs can increase the AV nodal conductivity, resulting in paroxysmal tachycardia, right? You take this procainamide and quinidine, what are they doing? They are increasing the action potential duration. So once there is increase in the action potential duration, what is happening? The cell is in the phase of depolarization. That means what is your procainamide and quinidine they are doing? They are increasing the conductivity across the AV node. So once they increase the conductivity across the AV node, that will result in paroxysmal tachycardia. So what I want to tell you here is, in patients with atrial fibrillation, whenever you are using procainamide and as well as quinidine, you should definitely give them along with the AV nodal blocking agents. Why? Because now let me show you here. Now, so this is your a 4-chambered heart, right, wherein you have the right atrium. In this right atrium you have the SA node, and somewhere here over you have the AV node, right? You have the AV node, and you have the internodal fibers, right? You have the internodal fibers. Now the impulse from the SA node passes through the internodal fibers, then it enters into the AV node. From the AV node, the impulse, it passes into the bundle branches, that is right bundle branch and as well as the left bundle branch. In case of atrial fibrillation, the atria, they are abnormally firing, right? The atria, they fire nearly around 400 to 600 times in atrial fibrillation. So when all this atrial firing, once they pass through your AV node, then even the ventricle will also land up in ventricular tachycardia and ventricular fibrillation. So now if at all when you are giving procainamide and quinidine, what does this procainamide and quinidine will do? Procainamide and quinidine, they will increase the action potential duration, right? I have discussed that. Why do they increase the action potential duration? Because they block the potassium channels. Now that means this procainamide and quinidine, they are trying to keep the cell in a phase of depolarization, right? They are trying to keep the cell in a phase of depolarization. That means when you are giving procainamide and as well as quinidine, what do? They will see that the cell is in the state of depolarization, and thereby the fibrillating atria can send their impulse through the AV node into the ventricle, resulting in the paroxysmal tachycardia. So in order to avoid that particular paroxysmal tachycardia, what you do is you block this AV node, right? You block this AV node. So how can you block this AV node? By AV nodal blocking agents, that is digoxin, verapamil and as well as beta blockers. Alright. So when you use these particular drugs, the advantage is the individual will not land up in paroxysmal tachycardia. Alright. So why are we using these drugs? Because this procainamide and quinidine, right, procainamide and quinidine, they increase, right, they increase AV nodal conductivity, right, they increase the AV nodal conductivity, resulting in paroxysmal tachycardia. Right, resulting in paroxysmal tachycardia. So this is about the class 1A agents. So let me shortly revise up to here what we have discussed. Remember, procainamide, it is a derivative of a procaine. Procaine, it is a local anesthetic, and this particular procainamide, it is given orally. And this procainamide, remember, it is metabolized in the liver by acetylation to produce N-acetyl procainamide. And that particular N-acetyl procainamide, it retains the potassium channel blocking activity. And you take this acetylation, right? You have the fast and as well as the slow acetylators of the procainamide, which is almost similar to that of your isoniazid, which is a first line anti-tubercular drug. A point what you should remember is the long-term therapy. Long-term therapy with high dose of this drug can result in drug-induced lupus erythematosus, particularly in case of the slow acetylators. Now, where all we use this class 1A agents? The indications for class 1A agents, they are supraventricular tachycardia, symptomatic ventricular premature beats, and as well as the prevention of ventricular fibrillation. Now, while procainamide and quinidine may be used for the conversion of the atrial fibrillation to normal sinus rhythm, they should only be used in conjunction with AV node blocking agents like digoxin, verapamil or a beta blocker, because these drugs, that is procainamide and quinidine, can increase the AV nodal conductivity, resulting in paroxysmal tachycardia. Now let me discuss about the class 1B agents. If you take this class 1B agents, the class 1B antiarrhythmic agents, they include lidocaine, alright, they include lidocaine, and the next drug is what is called as mexiletine, right, mexiletine, and next we have tokainide, and then we have phenytoin, right, then we have phenytoin. So these are the class 1B antiarrhythmic agents, that is lidocaine, mexiletine, tokainide, and as well as the phenytoin. Now let me tell you the mechanism of action of this class 1B agents. So remember, these are the sodium channel blockers, alright, these are the sodium channel blockers, and along with the sodium channel blocking activity, right, along with the sodium channel blocking activity, these drugs, they also possess the potassium channel opening property, right, they possess potassium channel opening property, alright. So this is what is the mechanism for lidocaine, mexiletine, tokainide, and as well as phenytoin. Now a point what you should understand here is, what are they doing to the potassium channels? They are seeing that the potassium channels are being opened. So once the potassium channels are being opened along with the sodium blockade, what does these drugs do? These drugs will try to exit the potassium out of the cell very fastly. So that is the reason why the class 1B agents, they have the fast onset and offset kinetics. Okay, so these class 1B agents, they have fast onset and fast offset kinetics, right, they have fast onset and as well as the offset kinetics. So how much is that? That is less than 1 second, right, that is less than 1 second, right. Now let me tell you, what does that mean? It means that they have little or no effect on the slow heart rates, and they have the more effect on the faster heart rates. So what I want to tell you is, this class 1B agents, they have the effect on the faster heart rates, right, they have the effect on the faster heart rates. Now the other point is, these agents, what are they doing? They are opening the potassium channels, they are causing the movement of the potassium channels out of the cell. So these agents, they shorten the action potential duration and they reduce the refractoriness. Okay, so these agents, they shorten the action potential duration and they reduce they reduce the refractoriness, right, they reduce the refractoriness. Now why is that they are shortening the action potential duration and reducing the refractoriness? Because of the opening of the potassium channels, right, because of opening of, right, because of the opening of the potassium channels, they will reduce the refractoriness and they will also shorten the action potential duration. Now the other point is, these agents, they will decrease the Vmax, right, they will decrease the velocity maximum. Why? Because they are blocking the sodium channels. So once the sodium channels are blocked, there is no rapid depolarization. So that is, these agents, they will reduce the Vmax in partially the action potential duration in non-depolarized tissues. So remember a point here, these drugs, they will decrease the Vmax. Now, these drugs are used only for ventricular arrhythmias, right? They are used only for They are used only for the ventricular arrhythmias. So, among the class 1B agents, the antiarrhythmic drug which is most commonly used is the lidocaine. So, if you take lidocaine, right, this is one of the most commonly used local anesthetic agent. Right, this is most commonly used local anesthetic agent as an antiarrhythmic drug in class 1B. Now, a point what you should remember is, if you take this lidocaine, remember lidocaine, it has very high first pass metabolism. Because it has very high first pass metabolism, therefore lidocaine is administered only by the intravenous route. Okay, so lidocaine, if you see, it has very high first pass metabolism, right? Very high first pass metabolism. Now, because it is having very high first pass metabolism, therefore it is administered by the intravenous route, right? Therefore it is administered by the intravenous route. Now, let me tell you another important point. You take the adverse effects of this lidocaine. Whenever you give lidocaine in excessive dose, that can lead to the neurological toxicity. Okay, so excessive dose of lidocaine, what is the adverse effect is? That can lead to the neurological toxicity. Right, that can lead to the neurological toxicity. And what will be the neurological toxicity associated with the lidocaine is, it will cause drowsiness, right? It will cause paresthesia, right? It will cause drowsiness, paresthesia, convulsions, and as well as coma, right? Drowsiness, paresthesia, convulsions, and coma. Now, apart from this particular neurological toxicity, the excessive dose of this lidocaine will result in what is called as the myocardial depression. Right, will result in what is called as the myocardial depression. Okay, so this is the adverse effect associated with the lidocaine. Now, if you take one very important point regarding the lidocaine, remember lidocaine is the drug of choice for the treatment of ventricular arrhythmias due to digitalis toxicity, right? This is a very important multiple choice question. So, if you take lidocaine, this is considered to be the drug of choice for digitalis induced ventricular arrhythmias, right? Drug of choice for ventricular arrhythmias due to digitalis toxicity, right? Due to digitalis toxicity. Now, a point what you should remember is, this particular lidocaine is ineffective in atrial arrhythmias, right? This particular lidocaine is ineffective in case of the atrial arrhythmias. Alright. Now, apart from lidocaine, there is one more important drug in class 1B, that is called as mexiletine. Right. So, if you take this mexiletine, right, if you take this particular mexiletine, remember this mexiletine, it is one of the orally active agent, right? This mexiletine, this is one of the orally active lidocaine derivative with all the properties of lidocaine. So, A point what you should remember is 𝐾𝐳, it is derived from lidocaine. Right, it is derived from lidocaine, and this 𝐾𝐳, it has all the properties, right, it has all the properties similar to lidocaine. Right, it has all the properties which is similar to that of lidocaine. Now, so after lidocaine and 𝐾𝐳, we have one more class 1B agent, that is phenytoin. Right, so in 1B there is one more drug which is nothing but phenytoin. Now, what exactly is your phenytoin? Remember, phenytoin, it is one of the anti-epileptic drug. Alright, this is one of the anti-epileptic drug. Where do we use this phenytoin? Remember, this phenytoin can be used as an alternative to lidocaine for digitalis induced ventricular arrhythmias. Right? So where do we use this phenytoin is, this particular phenytoin, it is used as an alternative right, it is used as an alternative to lidocaine for digitalis induced ventricular arrhythmias. Right, that is the place where we use this phenytoin. So remember, phenytoin is a popular anti-epileptic drug and it is used as an alternative to lidocaine for digitalis induced ventricular arrhythmias. Next to the phenytoin, we have another very important drug in class 1B, that is your tokainide. Right, that is your tokainide. Now remember, in group 1B, that is class 1B, this particular drug tokainide, it is having similar name as group 1C drugs. Now what are your 1C drugs? They include enkenyide and as well as flecainide. Right? Now your tokainide is similar to that of enkenyide and as flecainide, but a point what you should remember is this particular tokainide, this is class 1B agent. Right, this is class 1B agent. And how is this given? This is given orally. Right, this is given orally. Right, but this particular tokainide, it is not used widely. Right, it is not used widely. Now why is this not used widely is because of risk of agranulocytosis. Okay, so right, this is not used widely because of risk of agranulocytosis. So that is about your tokainide. Now let me shortly revise all the antiarrhythmic drug in class 1B agents. Remember, the drug what we have is the lidocaine. Lidocaine is the most commonly used local anesthetic agent, and a point is it has very high first pass metabolism. That is the reason why it is given by the intravenous route. And if you take the adverse effects of this lidocaine, the excessive dose can lead to the neurological toxicity and as well as myocardial depression. The neurological toxicity, it includes drowsiness, paresthesia, convulsions and as well as coma. Now if you take this lidocaine, it is the drug of choice for the treatment of ventricular arrhythmias due to digitalis toxicity. A point what you should remember is this particular lidocaine is ineffective in case of the atrial arrhythmias. Alright, next you have another class 1B agent, that is 𝐾𝐳. 𝐾𝐳, the route of administration is the oral route of administration and it is derived from the lidocaine. And this 𝐾𝐳, it has all the properties of the lidocaine. Now you take the other important drug, that is phenytoin. It is a popular anti-epileptic drug and it can be used as an alternative to lidocaine for digitalis induced ventricular arrhythmias. Next, the other drug what we have is the tokainide. Tokainide, the route of administration is the oral route of administration, but it is not used widely because of risk of the agranulocytosis. Now let me discuss about the class 1C agents. Now if you see the mechanism of action of these 1C agents, as such they have the property of the class 1 antiarrhythmic drugs, that is the sodium channel blocking effects. But the point what you should remember is these agents, they have most potent sodium channel blocking effects, right? So these drugs, they have most potent sodium channel most potent sodium channel blocking effect. Alright, next. Now a point is, now how did we classify the class 1 agents again? Class 1 we have classified into A, B and C depending upon their action on the potassium channels. You take class 1A agents, they were closing the potassium channels. You take class 1B agents, they were opening the potassium channels. Whereas you take class 1C agents, they have negligible effect on the potassium channels. Right? They have negligible effect on the potassium channels. Right, they have negligible effect on the potassium channels. Now a point what you should remember is, because they have negligible effect on the potassium channels, therefore there is no effect on the action potential duration of this class 1C agents. Okay, so therefore there is no effect on there is no effect on the action potential duration. Now these class 1C agents, they have a slow kinetics, right? They have slow kinetics, so that is more than 10 seconds, right? That is more than 10 seconds. Now you need to know what are the drugs in this class 1C agents. The drugs in class 1C agents include, one is flecainide, and then you have encainide, right? You have what is called flecainide, and then you have encainide, and then you have morphine and as well as propafenone. So you have propafenone, and the other drug what you have is morphine. So these are the antiarrhythmic drugs in class 1C. Now a point what you should remember regarding class 1C is, these drugs, they have maximum, right? These drugs, they have maximum proarrhythmic these drugs, they have maximum proarrhythmic property. Now this is a very important point what I am going to tell you. Because they have maximum proarrhythmic property, therefore these class 1C agents, they are indicated only for the resistant and life threatening ventricular tachycardias or ventricular fibrillations. Okay, so so they are indicated for they are indicated for resistant and life threatening ventricular arrhythmias. They are indicated for resistant and life threatening ventricular arrhythmias, and these ventricular arrhythmias include either ventricular tachycardia or the ventricular fibrillation. Now not only for the ventricular arrhythmias, these are also indicated for the treatment of refractory supraventricular tachycardia, also indicated for refractory supraventricular tachycardia. Now, you take the drug, right, that is flecainide. So, if you take this flecainide, right, if you see this particular flecainide, remember this flecainide can be used for acute treatment of Wolff-Parkinson's-White syndrome, right? This can be used for this can be used for the acute treatment of Wolff-Parkinson's-White syndrome. Now, what is your WPW syndrome? WPW syndrome, this is one of the pre-excitation syndrome, right? There is presence of an accessory bundle in patients with the Wolff-Parkinson's-White syndrome, right? Normally, in between the SA node and AV node, you have anterior, middle and as well as posterior internodal fibers. Whereas in WPW syndrome, apart from these three internodal fibers between SA node and AV node, there is an accessory bundle from the SA node directly to the ventricle. So, in such clinical scenario of WPW syndrome, for the acute treatment, what we give is flecainide. But if you take the treatment of choice in case of WPW syndrome, the treatment of choice for WPW syndrome is radiofrequency ablation of the aberrant pathway, right? So, the treatment of choice is radiofrequency ablation, right? The treatment of choice is the radiofrequency ablation of that accessory bundle, or it is also called as the aberrant pathway, right? Also called as the aberrant pathway. Now, after having discussed about the class 1 agents, let me discuss about the class 2 agents. Remember, class 2 agents, they are conventional beta blockers. Alright, they are conventional beta blockers, right? That is your class 2 agents. Now, how do they act? Remember, the mechanism of action of these particular drugs is they act by blocking the effects of adrenaline and noradrenaline at the beta 1 receptors which are present on the heart. Now, once the beta 1 receptors are being blocked, thereby there is decrease in the sympathetic activity on the heart. Okay, so if you take the class 2 agents, they act by blocking the effects of, right, they act by blocking the effects of, right, blocking the effects of adrenaline and noradrenaline at beta 1 receptors, right? Where are these beta 1 receptors present? They are present on the heart. So once these particular beta 1 receptors are being blocked, there is decrease in the sympathetic activity on the heart, right? There is decrease in the, right, there is decrease in the sympathetic activity on the heart. Alright, next. Now let me tell you another very important point here. If you take these agents are particularly useful in the treatment of supraventricular tachycardias, right? These agents, they are particularly useful in the treatment of, right, in the treatment of the supraventricular tachycardias. Now, another very important point is that if you take these class 2 agents, these drugs, they decrease the slope of phase 4. Right, what is your phase 4? Phase 4 is your resting membrane potential. So, remember, these drugs, they decrease the slope of, right, they decrease the slope of the phase 4. And once there is decrease in the slope of phase 4, that is responsible for automaticity. Right, that is responsible for, right, that is responsible for automaticity. And not only that, these drugs, as they decrease the slope of phase 4, and they also decrease the conduction through the AV node, right? These are the AV nodal blocking agents, okay? So these drugs, they also decrease, right? They also decrease the conduction through the AV node, right? They also decrease the conduction through the AV node. Now let me tell you the examples of the important beta blockers. The important beta blockers used as antiarrhythmic agents are, right, number one we have esmolol. Right, esmolol is one of the important beta blocker. Next to the esmolol we have propranolol. Right, next to the esmolol we have another important beta blocker, that is propranolol, and next to that we have metoprolol. Right, next to that what we have is the metoprolol. Now let me tell you an important multiple choice question here. So esmolol, propranolol and metoprolol, these are the important beta blockers which are used as antiarrhythmic agents. Right, which are used as antiarrhythmic agents. Now the multiple choice question here is, you take esmolol. Esmolol is the shortest acting beta blocker. Right, this is the shortest acting beta blocker. Right, so that is one of the important point regarding the esmolol. Now where is this used? Because it is shortest acting, it can be used intravenously for the emergency control of the ventricular rate in atrial fibrillation or atrial flutter. So this esmolol, remember, it is used intravenously, right? It is used intravenously, and it is used intravenously for the emergency control of, right, for the emergency control of ventricular rate, right, for the emergency control of ventricular rate in atrial flutter or atrial fibrillation. Right, so for emergency control of ventricular rate in atrial flutter or atrial fibrillation. So this is about your class 2 agents. So let me shortly revise about class 2 agents. Remember, these are the conventional beta blockers. And how do they act? They act by blocking the effects of adrenaline and noradrenaline at the beta 1 receptors and thereby decreasing the sympathetic activity on the heart. And these agents, they are particularly useful in the treatment of the supraventricular tachycardias. And a point what you need to remember is, these drugs, they decrease the slope of phase 4 and they also decrease the conduction through the AV node. Phase 4 is responsible for the automaticity. Now the drugs, if you take, the important beta blockers used as an antiarrhythmic agents are esmolol, propranolol and as well as the metoprolol. And you take the esmolol. Esmolol, it is the shortest acting beta blocker. And if you take the route of administration of this esmolol, it is used intravenously for the emergency control of ventricular rate in atrial flutter and as well as the atrial fibrillation. So this is about your class 2 agents. After having discussed about the class 2 agents, now let me discuss about the class 3 agents. Right, let me discuss about the class 3 agents. Now, if you take this particular class 3 agents, remember, class 3 agents predominantly they block the potassium channels, right? So, mechanism of action of the class 3 agents is they predominantly block the potassium channels. Right, they predominantly block the potassium channels. Now, because predominantly they block the potassium channels, what does these drugs do? Remember, they will prolong the repolarization. Okay, so because of the blocking of the potassium channels, there is prolongation of, right, there is prolongation of repolarization. Right, there is prolongation of the repolarization. Because the repolarization is being prolonged, there is also prolongation of the action potential duration. Right, prolongation of the action potential duration. Now, a point what you should remember here is, because there is prolongation of the action potential duration, these drugs, they may precipitate the Torsades-D pointers. Okay, so these drugs, they may precipitate Torsades-D pointers. Okay, now a very important point what you should remember here is, because there is prolongation of the action potential duration, there is prolongation of the QT interval, right? There is prolongation of the QT interval. Now, because there is prolongation of the QT interval, that may precipitate the development of the Torsades-D pointers. And what is your Torsades-D pointers? It is a form of polymorphic ventricular tachycardia. Right? It is a form of polymorphic ventricular tachycardia. So, this is about the drugs causing the Torsades-D pointers. Next, if you see these drugs, remember these drugs, they exhibit reverse use dependent prolongation of the action potential duration. Okay, so these drugs, remember, they exhibit what is called as reverse use dependent prolongation. Right, reverse use right, they will cause the reverse use dependent prolongation of the action potential duration, right, of the action potential duration. Now, what does that mean? Right, they exhibit what is called reverse use dependent prolongation of the action potential duration. This means that the refractoriness increases at lower heart rates. That is, the refractoriness of this particular drugs acting as antiarrhythmic drugs, they increases at lower heart rates. Therefore, these drugs, they are more efficacious at preventing a tachyarrhythmia than treating it. So, these drugs, they don't act at the lower heart rates. Where do they act? They act only whenever there is a tachyarrhythmia, or they are more efficacious at preventing the tachyarrhythmia than treating it. Okay, so what does this particular reverse use dependent prolongation of the action potential duration is? This means that, right, this means that refractoriness increases at the lower heart rates, right, and therefore these agents, right, therefore these agents are useful for preventing the tachyarrhythmia, right, therefore these agents are useful for preventing the tachyarrhythmias then, right, then treating it. Alright, now because of this property, class 3 antiarrhythmic agents may paradoxically be more arrhythmogenic at lower heart rates, right. So remember, at lower heart rates, these drugs should not be given because of this particular property of reverse use dependent prolongation of the action potential duration. They may be more arrhythmogenic. That means at the lower heart rates, what are they doing? They are prolonging the action potential duration. Thereby there will be prolongation of the QT interval, and thereby there will be development of Torsades-D pointers. Okay, so because of this particular property of reverse use dependent prolongation of the action potential duration, these class 3 antiarrhythmic agents may paradoxically be more arrhythmogenic at lower heart rates. Okay, so at lower heart rates, these are more arrhythmogenic. Okay, so that is the reason why at the lower heart rates we don't use these particular antiarrhythmic agents. Now you take the drugs in this particular class 3 antiarrhythmic agents. If you take, let me tell you the drugs in this class 3 in the form of a mnemonic, right? What is that particular mnemonic is? The mnemonic is Bindas. Right? Now you take the word B. B stands for beryllium, I stands for ibutylite, you take D stands for dronedarone, right? D stands for dronedarone, and then not only dronedarone, we have another important drug that is called as dophytilide, right? D stands for dronedarone or dophytilide. Next, if you take A stands for amiodarone and S stands for sotalol, right? S stands for sotalol. So class 3 agents, if you take beryllium, ibutylite, dophytilide or dronedarone, amiodarone and then sotalol, right? So before going into the further part of the discussion, let me shortly revise here. You take class 3 agents. This particular class 3 agents, the mechanism of action is they act by blocking the potassium channels and thereby prolonging the repolarization. That is, they will cause the prolongation of the action potential duration. Because they cause the prolongation of the action potential duration, they may prolong the QT interval. And because of the prolongation of the QT interval, these drugs may precipitate the 𝐃𝐨𝐳𝐳 pointus, which is a form of polymorphic ventricular tachycardia. And these drugs, they exhibit what is called as reverse use dependent prolongation of the action potential duration. This means that, right, this means that the refractoriness increases at lower heart rates and therefore these are more efficacious at preventing the tachyarrhythmia rather than treating the trachyarrhythmias. Now let me discuss about the amiodarone of the class 3 agents. Right? Amiodarone of the class 3 agents. So if you take this particular amiodarone, it is one of the longest acting agent. Right? This is one of the longest acting agents. And if you take this particular amiodarone, the T-half of this particular amiodarone is around 3 to 8 weeks. Right, the T-half is around 3 to 8 weeks and it is one of the longest acting antiarrhythmic drug. Now, if you take another important point regarding the amiodarone, it possesses the action of all the antiarrhythmic drugs, right? This is a very important point. So, it possesses the property of all antiarrhythmic drugs, right? It possesses the property of all the antiarrhythmic drugs. That is, it has sodium channel blocking action, right? It has the sodium channel blocking action. It has beta blockade action. It has potassium channel blocking action, and not only that, it also has calcium channel blocking action, right? Not only that, it also has the calcium channel blocking action. Now, because the amiodarone has the property of blocking all these particular channels, or it also has the beta blocking property. Due to this mechanism of action, it is having widest antiarrhythmic spectrum, right? So because of all these, this amiodarone, it is having widest antiarrhythmic spectrum, right? It is having widest antiarrhythmic spectrum. Now, the another important point is this particular amiodarone, it carries less chances of causing Torsades-D pointers despite the prolongation of the QT interval, right? See, what we have discussed, these particular drugs, they block the potassium channels, and thereby there will be prolongation of the action potential duration, due to which there is prolongation of the QT interval, and due to which there is development of Torsades-D pointers. But the important point regarding the amiodarone is that this particular amiodarone, it carries less chances of causing Torsades-D pointers, right? This amiodarone, it is having less chances of developing Torsades-D pointers, right? Less chances of having the development of Torsades-D pointers. Now, if you take this amiodarone, it contains iodine, right? Amiodarone, it contains iodine, right? And how much of the iodine? Approximately 37.5%. That is the reason why this particular amiodarone can result in hyperthyroidism. Right, that is the reason why this amiodarone can result in hyperthyroidism. Now, we have a similar drug to that of amiodarone, that is dronedarone. So, similar drug, that is dronedarone, it do not contain iodine. Okay, so similar drug dronedarone, it does not contain iodine, right? It does not contain iodine. Now, the other important point regarding this amiodarone is, number one, it can cause hyperthyroidism because it contains iodine. The other important point is, this particular amiodarone can also cause hypothyroidism. Right, this amiodarone can also cause hypothyroidism. Now the question is, how does it cause hypothyroidism? It causes hypothyroidism by inhibiting the peripheral conversion of T4 to T3. Right? What will happen in the biosynthesis of the thyroid hormone is, like you take the peripheral step, right? From the follicular cells of the thyroid gland, T4 is released, that is tetraiodothyronine. This tetraiodothyronine, in the presence of the enzyme 5-deiodinase, right, in the presence of the enzyme 5-deiodinase, T4 is converted into T3. Now, whenever you give this particular amiodarone, what does this amiodarone will do? This amiodarone will inhibit this enzyme, that is 5-deiodinase. Once this enzyme is inhibited, then peripheral conversion of T4 to T3 does not occur, and that will result in hypothyroidism, because the active molecule of the thyroid is your T3, not your T4. Alright? Next, apart from the thyroid related disorder, you take the other adverse effects associated with the amiodarone. The other adverse effects include peripheral neuropathy. It will also cause, right, it will also cause the myocardial depression, and apart from that, this amiodarone will also cause pulmonary fibrosis, right, will also cause the pulmonary fibrosis, hepatotoxicity, right. It will also cause corneal microdeposits, right. It will also cause the corneal microdeposits and as well as the photosensitivity. Right, as well as the photosensitivity, right. So if you take this amiodarone, what are the indications of amiodarone? Remember, amiodarone is indicated for the treatment of refractory ventricular tachycardia or ventricular fibrillation, particularly in the setting of acute ischemia, right. So if you take the indications of the amiodarone, right, if you take the indications of the amiodarone, the indications are for the treatment of refractory VT or VF, right, refractory ventricular tachycardia or ventricular fibrillation, particularly in the setting of acute ischemia. Like for example, you take myocardial infarction, right, it is a setting of acute ischemia. So in such case, there may be chances of developing VT or VF, and in such clinical scenario, the amiodarone is useful. Now, this particular amiodarone is also safe to use in individuals with cardiomyopathy and atrial fibrillation to maintain the normal sinus rhythm, right. So the other indication is in patients with atrial fibrillation to maintain the normal sinus rhythm, we give this particular amiodarone. Next, the other point is this particular amiodarone, it can be used for the prophylaxis of almost all arrhythmias except 𝐃𝐨𝐬𝐳𝐳, right. So it is also given as prophylaxis in all arrhythmias, right, except 𝐃𝐨𝐬𝐳𝐳, right, except 𝐃𝐨𝐬𝐳𝐳. So these are the few important points regarding the amiodarone. So let me shortly revise about the amiodarone. Remember, amiodarone, it is one of the longest acting agents among all class 3 antiarrhythmic drugs, and the half-life of this particular amiodarone is around 3 to 8 weeks. And this particular amiodarone, it possesses the action of all the classes of antiarrhythmic drugs, that is sodium channel blockade, beta blockade, potassium channel blockade, and as well as the calcium channel blockade. Now, due to this property, right, it has the widest antiarrhythmic spectrum. And other important point is that this particular amiodarone, it carries less chances of causing 𝐃𝐨𝐬𝐳𝐳 and thereby it does not cause the polymorphic ventricular tachycardia, right. Next, this amiodarone, it contains the iodine, approximately 37.5%, and because it contains iodine, it can result in hyperthyroidism, and you have a similar drug to that of amiodarone, that is dronedarone. This particular dronedarone do not contain iodine. Next, the other important point is it can also cause hypothyroidism by inhibiting the peripheral conversion of T4 to T3. The other adverse effects of this amiodarone includes the peripheral neuropathy, myocardial depression, pulmonary fibrosis, hepatotoxicity, corneal microdeposits, and as well as the photosensitivity. And if you take the indications of this particular amiodarone, this amiodarone is indicated for the treatment of refractory ventricular tachycardia or ventricular fibrillation, particularly in the settings of acute ischemia. And remember, this amiodarone is also safe to use in individuals with cardiomyopathy and atrial fibrillation to maintain the normal sinus rhythm. And this amiodarone can be used for the prophylaxis of almost all antiarrhythmias except 𝐃𝐨𝐬𝐳𝐳. Now, regarding this amiodarone, like we have discussed many adverse effects. Now, let me tell you the adverse effects of amiodarone in the form of a mnemonic. Right, let me tell you the adverse effects of this particular amiodarone in the form of a mnemonic. The mnemonic is the periphery right? The periphery of my lung and liver, right? The periphery of my lung and liver and even cornea, right? The periphery of my lung, liver and cornea is photosensitive, right? It is photosensitive. This is the mnemonic. Now you take the word T. T stands for the thyroid related disorder. This amiodarone, it will cause hypo or hyperthyroidism. Right? It will cause hypo or hyperthyroidism. You take the word P, periphery. So that is, it will cause peripheral neuropathy. You take the word M, it will cause myocardial depression. Right? It will cause myocardial depression. And you take the word lung, that is, it will cause pulmonary fibrosis or lung fibrosis. And you take L, that is, it will cause liver toxicity. Right? That is, it will cause the liver toxicity. Right? Next, you take the word C. C stands for, that is cornea, that is corneal microdeposits. Right? Corneal microdeposits. And you take the word P, that is photosensitive, right? So it has the adverse effect of photosensitivity, right? Photosensitivity. All right. So these are the adverse effects associated with the amiodarone. Now after having discussed about the amiodarone, let me discuss about the other antiarrhythmic drug, that is dronedarone. Right? Another antiarrhythmic drug, that is dronedarone. Now, if you take this particular dronedarone, remember it is similar to that of amiodarone, but the difference is the dronedarone is non-iodinated compound. Right? Dronedarone, it is one of the non-iodinated compound. In the sense, this particular dronedarone does not contain iodine, right? It is one of the non-iodinated compound. Now, because it is non-iodinated compound, the dronedarone, there is very fewer adverse effects. Not only that, the dronedarone is also less efficacious than amiodarone. Okay, so it has few adverse effects. And the other important point is, it is less efficacious, right? It is less efficacious than, right? Less efficacious than amiodarone. Next, now where is this dronedarone given? Dronedarone, it is indicated for the atrial fibrillation, right? Indicated for atrial fibrillation and as well as the atrial flutter. Right? It is indicated for atrial fibrillation and as well as atrial flutter. Now, not only that, the other advantage of the dronedarone is it has lesser incidence of the pulmonary fibrosis, peripheral neuropathy and hypothyroidism. Right? Dronedarone, it is having lesser incidence of pulmonary fibrosis, right? Lesser incidence of the peripheral neuropathy, and the pulmonary fibrosis and peripheral neuropathy of this dronedarone is less compared to that of amiodarone, right? It is less compared to that of amiodarone. Next, now let me tell you another important agents in class 3. The other important agent is vernaculant, right? The other important agent is vernaculant. Now, if you take this particular vernaculant, what is this? This vernaculant, it is a multi-ion channel blocker, right? Because it is a multi-ion channel blocker, it will selectively prolong the atrial refractory period without affecting the ventricles. Okay, so what is this vernaculant is? This is one of the multi-ion channel blocker, right? This is one of the multi-ion channel blocker, and this particular vernaculant, it will prolong, that is, it selectively prolongs right? It selectively prolongs the atrial refractory period. Alright, it selectively prolongs the atrial refractory period. And this vernaculant, right, this vernaculant, it does not affect the ventricle, right, without affecting the ventricles, right, without affecting the ventricles. Now, because it is selectively prolonging the atrial refractory period, this vernaculant is indicated for converting atrial fibrillation of short duration to sinus rhythm, right? So what does this vernaculant do is, it will convert the atrial fibrillation of short duration. That means short duration means atrial fibrillation of less than 7 days. So it is indicated for converting the atrial fibrillation of short duration to sinus rhythm, right, to sinus rhythm. Now, the other important point regarding the vernaculant is, vernaculant, it has little or no proarrhythmic action, right, it has little or no proarrhythmic action, right? That is the important point regarding the vernaculant, right? So if you take this particular dronedarone, remember this is one of the non-iodinated agent, it does not contain iodine, so it has very fewer side effects, but also it is less efficacious than amiodarone, and it is indicated for atrial fibrillation and atrial flutter. And this dronedarone, it has lesser incidence of pulmonary fibrosis, peripheral neuropathy and hypothyroidism than the amiodarone. The other important agent here is vernaculant. If you take the vernaculant, it is one of the multi-ion channel blocker that selectively prolongs the atrial refractory period without affecting the ventricles. And this vernaculant, it is indicated for converting the atrial fibrillation of short duration to sinus rhythm. And this vernaculant, it has little or no proarrhythmic action. Now, let me discuss another class 3 agent, that is beryllium. Right, another class 3 agent, that is beryllium. So, if you take this particular beryllium, this is an adrenergic neuron blocking drug. Right, this is one of the adrenergic neuron blocking drug. Alright, now where is this particular beryllium used? Remember, beryllium, it is used only parenterally for arrhythmias. Right, it is used only parenterally for right? It is used only parenterally for arrhythmias. And the major adverse effect of the beryllium is it will cause what is called as postural hypotension. Right? This beryllium will cause what is called as the postural hypotension. Now, after having discussed about the beryllium, we have another important agent, that is sotalol. Right? Another important agent, that is sotalol. Now, if you take this sotalol, it is a non-selective lipid insoluble beta blocker. Right? It is a non-selective beta blocker. Right? It is a non-selective beta blocker, and this particular sotalol, it is lipid insoluble. Right? It is lipid insoluble beta blocker. Now, this particular sotalol, it has actions of both class 2 as well as class 3 antiarrhythmic agents. Right? This sotalol, it has the actions of both class 2 as well as class 3 antiarrhythmic agents. Right? It has the actions of both class 2 as well as class 3 antiarrhythmic agents. Now, where is this particular sotalol indicated? So, if you see the indications of sotalol, it is indicated for the treatment of atrial or ventricular tachyarrhythmias, and it is also useful for AV nodal reentrant tachycardias. Alright. So, if you take the indications of sotalol, this sotalol, it is indicated for atrial or ventricular arrhythmias. And not only that, it is also indicated for AV reentrant arrhythmias, that is atrioventricular reentrant arrhythmias. So that is the place where we use this sotalol. Now, after this sotalol, we have another important class 3 agent, that is ibutyllide. Right? Another important class 3 agent, that is ibutyllide. Now, if you take this ibutyllide, ibutyllide is a structural analog of sotalol. Okay? Ibutyllide, it is the structural analog of sotalol. But a point is, it is only a structural analog of sotalol. But this particular ibutyllide, it has no beta blocking property. Right? It has no beta blocking property. Right? It has no beta blocking property. And this particular ibutyllide, it is used for the treatment of atrial fibrillation or atrial flutter by intravenous route only. So ibutyllide, it is given by IV route only, and it is given in the treatment of atrial fibrillation and as well as the atrial flutter. Right? Given in the treatment of atrial fibrillation and as well as the atrial flutter. Now, if you take this particular ibutyllide, remember, ibutyllide is the only antiarrhythmic agent currently approved by the FDA for the acute conversion of atrial fibrillation to sinus rhythm. Okay, so it is currently approved drug by the FDA for acute conversion, right, for the acute conversion of the atrial fibrillation or atrial flutter to the normal sinus rhythm, right? And you take the other drugs. Other drugs used in atrial fibrillation, they also control the ventricular rate. whereas the point about the albuterol is it is approved by the FDA for the acute conversion of atrial fibrillation or atrial flutter to the sinus rhythm, whereas the other agents, they are used in atrial fibrillation, they are for controlling the ventricular rate, right, for controlling the ventricular rate. So if you take the other drugs which are used, right, other drugs which are used in atrial fibrillation are for controlling, right, for controlling the ventricular rate, right. So these are the important class 3 agents. So if you take this particular beryllium, this is an adrenergic neuron blocking drugs used only parenterally for arrhythmias, and the major adverse effect of this beryllium is the postural hypotension. And you have another important class 3 agent, that is sotalol. Sotalol is a non-selective lipid insoluble beta blocker, and it has the actions of both class 2 as well as class 3 antiarrhythmic agents. And where is this indicated? Indications are in case of atrial or ventricular tachyarrhythmias, and it is also indicated in case of AV reentrant arrhythmias. Now if you take ibutyllite, it is given intravenously only, and it is the structural analog of sotalol, but it has no beta blocking property. And if you take this ibutyllite is the only antiarrhythmic agent currently approved by FDA for the acute conversion of atrial fibrillation to normal sinus rhythm, whereas other drugs used in atrial fibrillation are for controlling the ventricular rate. So this is completely about the discussion on the class 3 agents. Now let me discuss about the class 4 agents. Right, let me discuss about the class 4 agents. Now if you take this class 4 agents, remember these are the blockers of the calcium channels, right, they block the calcium channels. But the multiple choice question here is, which type of calcium channels are being blocked by the class 4 agents? Class 4 agents, they are the blockers of L-type voltage gated calcium channels, right, they are the blockers of L-type, right, they are the blockers of L-type voltage gated calcium channels. Now these class 4 agents, they decrease the rate of phase 4 depolarization in SA node and AV node, okay. So they decrease the rate of phase 4 depolarization, right, they decrease the rate of phase 4 depolarization in SA and as well as the AV nodes, right, in the SA node and as well as the AV node. Now the other point is, because they decrease the rate of phase 4 depolarization in SA node and AV node, this results in decreased automaticity of SA node and decreased conduction through the AV node, right. So this results in decreased automaticity of SA node, right, this will result in decreased automaticity of the SA node and decreased conduction through AV node, right, decreased automaticity of SA node and decreased conduction through the AV node. Now if you take the drugs they include verapamil and diltiazem, right, verapamil and as well as diltiazem. So verapamil and diltiazem, they are mainly indicated for, right, they are mainly indicated for paroxysmal supraventricular tachycardia, and not only that, they are also indicated for control of ventricular rate in atrial fibrillation and atrial flutter, right. So they are also indicated for control of ventricular rate in atrial fibrillation and as well as the atrial flutter, right, also useful for the control of the ventricular rate in atrial fibrillation and atrial flutter. Now you take this verapamil. So if you see this verapamil, remember it is the drug of choice for the treatment of supraventricular tachycardia, and not only that, it is the drug of choice for the prophylaxis of paroxysmal supraventricular tachycardia, right? It is the drug of choice, right? It is the drug of choice for the treatment of SVT, and it is also the drug of choice for, right? It is also the drug of choice for prophylaxis of paroxysmal supraventricular tachycardia. So these are few points about your class 4 agents, right? Class 4 agents, remember, they are the blockers of L-type voltage gated calcium channels. They decrease the rate of phase 4 depolarization in SA node and as well as AV node, and this results in decreased automaticity of SA node and decreased conduction through the AV node. And you take verapamil and diltiazem, they are mainly indicated for paroxysmal supraventricular tachycardia and for control of ventricular rate in atrial fibrillation and atrial flutter. And if you take verapamil, it is the drug of choice for the treatment of SVT, and as well as it is also the drug of choice for the prophylaxis of paroxysmal supraventricular tachycardia. Now let me discuss about the class 5 agents. So if you take the class 5 agents, the examples they include digoxin, they include adenosine, right? They include adenosine. The other drugs are magnesium, and then we have atropine, and the other drugs are even your potassium, right? Even your potassium. Now let me discuss one by one. You take the drug that is digoxin, right? You take the drug that is digoxin. Remember, digoxin, it increases the vagal activity, right? Now because it increases the vagal activity, so digoxin, it increases the vagal activity. So remember, because digoxin increases the vagal activity, it is used for controlling the ventricular rate in atrial fibrillation, right? In atrial fibrillation and as well as the atrial flutter, right? Atrial fibrillation and atrial flutter. So that is about your digoxin. Next, you take the other important drug that is adenosine, right? The other important drug that is adenosine. Now if you see this adenosine, remember, adenosine, it opens the potassium channels. Because the adenosine opens the potassium channels, this adenosine, it leads to the hyperpolarization of the AV node, right? Adenosine, it opens the potassium channels, right? Now, so once there is opening of the potassium channels, what will happen? There is hyperpolarization of the AV node. So this leads to hyperpolarization of the AV node. Now because there is hyperpolarization of the AV node it gets inhibited. Now once the AV node is being inhibited, the impulses from atria will not reach the ventricle, and thereby it is used as the drug of choice for the treatment of PSVT, right? Drug of choice for paroxysmal supraventricular tachycardia. Now the very important point is the adenosine, it is very short acting drug, right? It is a very short acting agent, and if you take the T-half, the T-half is around 10 seconds, right? The T-half is around 10 seconds. Now because the adenosine, it has the T-half of only 10 seconds, therefore the adverse effects like flushing of the face and bronchospasm, they are also short-lived, right? So the adverse effects like flushing of the face and as well as bronchospasm, right? As well as the bronchospasm, they are short-lived, right? They are short-lived. Next, now you take the other drug that is, now continuing this adenosine, remember we have a drug called as theophylline. Theophylline, it is an adenosine receptor antagonist. Remember, theophylline, it is an adenosine receptor antagonist. Because theophylline inhibits the adenosine receptor, theophylline, right? Theophylline, it is adenosine, right? It is adenosine receptor antagonist, right? It is an adenosine receptor antagonist. Now because theophylline is an adenosine receptor antagonist, theophylline inhibits the action of the adenosine, right? Inhibits the action of the adenosine. Whereas you take the other agent is your dipyridamole, right? The other agent is dipyridamole. So if you take this particular dipyridamole, it potentiates the action of the theophylline by inhibiting the reuptake of adenosine. Okay, so dipyridamole, right? Dipyridamole, it potentiates the action of adenosine by inhibiting the reuptake, right? By inhibiting the reuptake of adenosine, right? By inhibiting the reuptake of adenosine, right? So these are important points regarding the adenosine. Now we have the important agent, that is magnesium. Remember, magnesium is used for the treatment of both congenital and acquired long QT syndrome, right? This is a very important multiple choice question. So it is used for, right, it is used for congenital and acquired long QT syndrome, right? So that is the important point regarding the magnesium. So let me shortly revise the class 5 agents. The class 5 agents, they include digoxin, adenosine, magnesium, atropine, and as well as the potassium. And if you take the digoxin, it increases the vagal activity and it is useful for controlling the ventricular rate in atrial fibrillation and atrial flutter. And the other agent, if you take adenosine opens the potassium channels and lead to hyperpolarization of the AV node. And this adenosine, it is a drug of choice for the treatment of paroxysmal supraventricular tachycardia. And it is a very short acting agent. The T-half is around 10 seconds. And therefore, the adverse effects like flushing of the face and bronchospasm, they are also short-lived. And if you take an agent called theophylline being adenosine receptor antagonist, inhibits the action of the adenosine. Whereas you take dipyridamole, it potentiates the action of the adenosine by inhibiting the reuptake of adenosine. And if you take magnesium is used for the treatment of both congenital and as well as acquired long QT syndrome. Now let me tell you the drug of choice or the drug treatment of the various arrhythmias, right? Summarizing all the arrhythmias, let me tell you what is the drug of choice for the acute therapy, drug of choice for the chronic therapy, and associated remarks. Now you take the type of arrhythmia, right? You take the type of arrhythmia. Now for example, you take the type of arrhythmia in case of the atrial fibrillation or the atrial flutter, right? Atrial fibrillation or atrial flutter. Now what is the drug of choice for acute therapy in atrial fibrillation or the atrial flutter? So in case of, or for acute therapy, the drug of choice is propranolol and as well as the esmolol, right? Propranolol and as well as esmolol. Now you take the drug of choice for the chronic therapy, right? Drug of choice for the chronic therapy. For chronic therapy, the drugs used in case of atrial fibrillation or atrial flutter is, we give digoxin. The other drug of choice is your ibutylide, right? And apart from this digoxin, ibutylide, the other drugs what we have is amiodarone and as well as verapamil, right? Amiodarone and as well as verapamil. Now there are certain remarks as well. And if you take this particular remarks here, remember only ibutylide is indicated for conversion to sinus rhythm. The other drugs, they control the ventricular rates only. Okay, so you take the ibutylide. Ibutylide is the only drug which is used for conversion of the atrial fibrillation or atrial flutter to sinus rhythm. The other agents, right, other agents, they control the ventricular rate. Right, other agents, they control the ventricular rates only. Now, so this is in case of atrial fibrillation or atrial flutter. Now, you take in case of PSVT, that is paroxysmal supraventricular tachycardia. In PSVT, that is drugs used for acute therapy, they include adenosine. Right, they include adenosine. Now, whereas for the drug of choice for the chronic therapy, they include verapamil, they include sotalol, then propranolol, and as well as amiodarone. Right, as well as the amiodarone. Next, now after PSVT, remember you take in case of VT, that is ventricular tachycardia. In case of ventricular tachycardia, that is for the acute therapy, the drugs given are, right, the drugs given are lidocaine and as well as magnesium. And you take for the chronic therapy, the drugs for the chronic therapy in case of ventricular tachycardia, they include, right, they include sotalol, amiodarone, and apart from this sotalol and amiodarone, we have the other drug, that is quinidine. So these are the drugs which are given for the chronic therapy in case of ventricular tachycardia. Next, if you say in case of the ventricular fibrillation. So in case of ventricular fibrillation, you take the acute therapy. The drug of choice for the acute therapy in case of ventricular fibrillation is lidocaine, and the other drug apart from the lidocaine, it includes bretylium. Right, it includes bretylium. Now, for the chronic therapy in case of ventricular fibrillation, we give amiodarone. Right, we give amiodarone. Now remember, cardioversion is the treatment of choice in case of the ventricular fibrillation. Right, in case of hemodynamically unstable patients with ventricular fibrillation, cardioversion is the treatment of choice. Next, you take in case of WPW syndrome. Right, WPW syndrome. Now, in WPW syndrome, remember, for acute therapy, the drug of choice is flecainide. Right, the drug of choice is the flecainide. And for chronic therapy, we give propranolol and amiodarone. Right, propranolol and as well as amiodarone. Now, a point what you should remember is, in WPW syndrome, remember, laser ablation of aberrant pathway is the definitive treatment. So, laser ablation of the aberrant pathway. Right, this is the definitive treatment. Right, this is the definitive treatment for the Wolff-Parkinson's-White syndrome. Next, you take the type of arrhythmia, that is Torsades-de Pointes. Right, Torsades-de Pointes. In case of Torsades-de Pointes, the drug of choice for acute therapy is your magnesium. Right, the drug of choice for the acute therapy is magnesium. That is for both congenital and as well as acquired long QT syndrome, the drug of choice is magnesium. And but for chronic therapy, we give propranolol. But remember, propranolol, it is only for chronic. Right, propranolol is only for chronic. Right, in case of Torsades-de Pointes, amiodarone should not be used. So remember this point, amiodarone should not be used. Next, you see in case of digitalis induced arrhythmia. Right, in case of the digitalis induced arrhythmias. So digitalis induced ventricular arrhythmias, the drug of choice for the acute therapy is lidocaine and as well as phenytoin. Right, lidocaine and as well as phenytoin. And for chronic therapy, we give propranolol. Right, for chronic therapy, we give propranolol. Now remarks are, for bradyarrhythmia, atropine can be used. Right, in case of digitalis induced bradyarrhythmias, atropine can be used. Right, this is for the bradyarrhythmias. Alright, remember regarding an important point regarding the amiodarone. Amiodarone can be used for the chronic treatment of all arrhythmias except Torsades de Pointes and digitalis induced arrhythmias. Okay, this is a very important point regarding the amiodarone. So remember, amiodarone can be used for chronic treatment of all arrhythmias except Torsades de Pointes and digitalis induced arrhythmias. So this completes the discussion on the antiarrhythmic drugs.